Hello, and welcome to the Clinical Care Options Oncology Podcast. I'm your host, Hemia Bajimi. Today's episode features perspectives from a medical oncologist, nurse practitioner, and pharmacist on the important role of the multidisciplinary team in achieving comprehensive and individualized care of patients with hormone receptor positive, HER2 negative metastatic breast cancer, especially those with pre-existing medical conditions. This episode is part of a larger educational program titled Comprehensive Patient-Centric Care in Hormone Receptor Positive, HER2 Negative Metastatic Breast Cancer, meeting the full spectrum of patient needs with comorbidities and related factors. This podcast features Dr. Sara Hurvitz, Professor of Medicine, Smith Family Endowed Chair in Women's Health at the University of Washington, and Senior Vice President, Clinical Research Division at the Fred Hutch Cancer Center in Seattle, Washington. Ms. La-Urshalar B, a nurse practitioner at the Emory University Nell Hudson Woodruff School of Nursing in Atlanta, Georgia, and Dr. Jordan Hill, a clinical pharmacy specialist, breast oncology at the West Virginia University Cancer Institute in Morgantown, West Virginia. Together, they will be reviewing key comorbidities in patients with hormone receptor positive, HER2 negative metastatic breast cancer, the impact of polypharmacy on treatment outcomes, role of advanced practice providers in achieving comprehensive patient care, the role of CDK4/6 inhibitors and other treatments used for hormone receptor positive, HER2 negative metastatic breast cancer, the utility of real-world evidence data sets, how to communicate treatment options with patients and their caregivers, and coordinating with a multidisciplinary team in individualizing treatment and maximizing quality of life for patients with hormone receptor positive, HER2 negative metastatic breast cancer. For more information on Dr. Sara Hurvitz, Ms. La-Urshalar B, and Dr. Jordan Hill, along with a link to the complete program, including the associated podcasts, downloadable slides, certified text modules, and certified video module, please visit the show notes for this episode. Now let's get started and hear what the experts have to say on this important topic.
Hello, welcome to Role of the Multidisciplinary Team in Achieving Comprehensive and Individualized Care of Patients with Hormone Receptor Positive, HER2 Negative Metastatic Breast Cancer and Preexisting Comorbidities. I'm Dr. Sara Hurvitz. I'm a professor of medicine and Smith Family Endowed Chair in Women's Health and head of the Division of Hematology Oncology at the University of Washington and senior vice president of the Clinical Research Division at the Fred Hutch Cancer Center. And I'm really pleased to be joined here today by two esteemed colleagues, La-Urshalar B, nurse practitioner. La-Urshalar, can you introduce yourself, please?
Yes, thank you so much, Dr. Hurvitz. My name is La-Urshalar B, and I am a family nurse practitioner and a certified nurse midwife at Winship Cancer Institute at Emory University, where I work in the breast specialty in medical oncology. I'm also a PhD graduate at the Laney Graduate School of Emory University, Neil Hodgson Woodruff School of Nursing in Atlanta, Georgia.
Welcome. So happy you're here today to give your perspective. I'm also really happy to be here with Jordan Hill, a pharmacist. Jordan, do you want to introduce yourself?
Thank you. My name is Jordan Hill. I am an oncology pharmacist that specializes in breast oncology at the West Virginia University Cancer Institute in Morgantown, West Virginia.
This is going to be a great discussion. Today, we're going to be talking about comorbidities in patients with metastatic breast cancer that's hormonally driven. Talk about topics including how polypharmacy can impact our patients' care, the role of APPs in comprehensive care of our patients who are contending with metastatic breast cancer, optimizing the use of novel agents like CDK4/6 inhibitors and other treatments, taking into account their risks and benefits and real-world evidence, communicating treatment options with patients and their caregivers, understanding patient goals, and coordinating with a multidisciplinary team to individualize treatment and maximize quality of life. So without further ado, let's get into the meat of our discussion and first start by talking about comorbidities that we frequently see in our patients who have been diagnosed with hormone receptor positive, HER2 negative metastatic breast cancer. And for this, I'm going to turn to La-Urshalar. Can you go through some of the common comorbidities you are seeing in clinic in patients diagnosed with metastatic disease?
Yes, absolutely. We have, a wide variety of ages when we're thinking about metastatic breast cancer and who we see. But a lot of these patients come to us with either cardiovascular disease, whether it's hyperlipidemia, or they have high blood pressure that they're trying to control, or they have diabetes, which could be controlled or not controlled. Also, do they have any type of gastrointestinal dysfunction or swallowing dysfunction that could hinder them taking their medication, as well as their performance status? Like, are they frail? Is their performance status good? And then also any type of infections that they might have or have had in the past. So these are the type of things that I usually see. I would say I see diabetes and hypertension and hyperlipidemia more often than anything else, but there are quite a few people that do have some GI dysfunction.
Yeah, and I guess as we are thinking about trying to start systemic therapy for patients with newly diagnosed hormone receptor positive metastatic breast cancer, we have so many treatment options. And so considering these various comorbidities can really impact how we select among the various agents. I think that your points regarding diabetes and cardiovascular and GI dysfunction, those are really impactful when we're selecting among, for example, the CDK4/6 inhibitors that are available to us. We know that so many patients have metabolic syndrome. Obesity is really a crisis in America, and so it's very common to have these. I'm wondering, Jordan, how you approach patients when you see a prescription come through. Maybe I'm not sure how your practice is structured, but when you see a prescription come through, and how do you consider these comorbidities? Is it more looking at the other medications that a patient's taking, or are you taking more of a broader approach as you're considering the doses and the toxicity that patients may experience?
Can definitely be each of those, especially depending on, like you mentioned, where the pharmacist is practicing. I primarily work in our breast oncology clinics with our breast oncologists as well as our APPs in those clinics. And so I am kind of evaluating them on the entire scale of things, whether that be what other comorbidities they have and how that can impact how they're going to tolerate the medication, as well as what other medicines they are taking that could also impact what medications we're able to choose from. We also do have oncology pharmacists that practice in the specialty pharmacies, and they are primarily going to be taking a closer look at the medication specifically, and maybe not as much into the kind of chronic comorbidities that concomitantly can happen in these patients, knowing that on the clinic side, the rest of us have kind of done that aspect of it. And so they kind of are looking at a more closer level at just the medications themselves and the dose in relation to what other medicine they're on.
Excellent points. And I think, of course, we have to be talking to our patients about their own personal values, their support system, whether they can come into clinic and have blood work done frequently and EKG monitoring and insurance coverage and the cost of treatment. I imagine, Jordan, you're having discussions regarding that and sometimes suggesting that the clinician order a different medication that is going to be more affordable for patients.
Absolutely. So we unfortunately are starting to see that more and more often, where certain medications will either have different copays or certain insurances will require step therapy. So they will actually require abemaciclib or ribociclib to be tried and failed before they will allow palbociclib. Kind of as we've mentioned, even just with these other common comorbidities, it is hard sometimes for these elderly patients that have a lot of common comorbidities to be able to tolerate certain medications. Sometimes there are indications to use other agents. And so often with some of our older patients that have a lot of these conditions, we do want to try palbociclib first, and they don't want us to without jumping through a lot of hoops, and that can cause delays in care. So We often are trying to help facilitate that with our providers, whether that be helping to write appeal letters describing why we want to use a non-preferred medication, or even just helping to get enrolled in patient assistance programs for patients that really have unacceptable copays and things that they are unable to afford. We can assist in that manner too. So financial toxicity is a real burden, and it definitely takes the entire team to help manage that.
Outstanding points that you're making here, and so totally clinically relevant. Ursula, can you talk about how you approach a patient when you're discussing their support system, their own personal values, and things in their lives that might interfere with their ability to adhere to therapy? These are sensitive but such critical topics to discuss.
So when our patients, whether we were treating them in early stage and then they become metastatic, or we're meeting them for the first time with their metastatic diagnosis, I mean, the first thing is usually, whether or not they are coming in with someone or not. So the first thing as I'm assessing when I see them is, are they with family members or are they alone? For the individuals that we have treated previously, we already kind of know them at that point. So you know whether or not they have a lot of family support or friend or coworker support, because we do have a lot of patients that come in with their coworkers or friends. So, and if we don't know them, just asking them what kind of support do they have? Do they feel comfortable about telling their family members? Because some patients don't at that point. And so we need to take that into account. I always just ask them up front, because usually we already know what we're going to recommend for them to take. And I'll say, this is what we're looking at in terms of treatment for you. How do you feel about this? And I will go over the side effects. Usually patients are pretty upfront about talking about what they're concerned about or worried about in terms of side effects that they may have experienced before, and they don't want to experience those same side effects. Like if they had bad nausea before, they had bad GI before, or if they're worried about losing their hair, because that's a big topic as well. So just talking to them and being upfront about what the potential side effects could be. Usually patients are very upfront with you when you start telling them, because they'll tell you that they don't want to do that. I want some other treatment. That's not what I want to deal with. And so then we come up with other options. I discuss with my oncologist. I say, she doesn't want to do this for this reason. We need to have another option for her. And I think that works really well, because that basically shows the patient that, we are willing to work with them. We want to treat them the best way we can. But we also want them to have their quality of life. That's how I go about in assessing someone's starting treatment.
That's really helpful, and it touches on so many salient points and the need for honesty and transparency. I think clinicians sometimes feel a little shy about telling them all the dark parts of going on therapy because we don't want to scare them off, but not being fully transparent gets you into trouble later. And I think having that honest discussion is certainly important. Jordan, I'm going to turn back to you right now and wanted to understand sort of your role in assessing patients who are using non-prescribed medications, vitamins, herbal supplements. How are you assessing that as a patient starting a new drug like a PI3 kinase inhibitor or a CDK4/6 inhibitor where drug-drug interactions can occur? And are there resources clinicians could utilize to help assess for drug-drug interactions and know what's safe when we're talking about these sort of non-traditional therapies that a lot of patients are using now?
Yeah, these are, as you mentioned, very commonly used. We see, in addition to the sometimes very complex medication list that they have of prescribed medications, half or more of patients are also going to be using supplements that may or may not be on their medication list. So it is very important to meet with patients to get a very detailed history of medications as well as the supplements that they are taking. I try to take it in a very non-judgmental approach. I know lots of people have lots of different feelings about supplements, and I find that people are most comfortable when approaching it in kind of an open and honest way, as we previously discussed, with kind of their goals of therapy and concerns about side effects is other things that they are taking and want to continue taking, and not necessarily discouraging them from doing so as long as we can ensure that it's safe. I think if you go into the conversation with, as long as we feel that this is not going to be unsafe, I'm not, going to tell you can or can't do things, you're more likely to get very honest responses as to the things that they could be taking outside of their medication list. That's probably step one. As far as helpful resources, I do think this is very challenging because we maybe don't know the most about the metabolism of some of these supplements. And so there is the potential that we wouldn't know about an interaction between them and their cancer therapies or even their other medications that we use for supportive care. And so doing the best we can. And what I usually try to do is, instead of using databases for looking at interactions, I actually try to find how they're metabolized. Because what you will find often is that they won't flag as an interaction, but when you compare how they are metabolized, you can definitely find some concerning things that may not flag. So Memorial Sloan Kettering has a pretty good database of a lot of complementary and alternative medicine that goes into a lot of good detail. And then Natural Medicines has a great database. Again, I try not to use the interaction function of, because that can miss a lot of things, but more of the preclinical or clinical studies that we have looking at their metabolism and then comparing that to their medication list and kind of doing the evaluation myself as opposed to the interaction checker.
Those were such helpful notes. And I have heard about the Memorial Sloan Kettering database. La-Urshalar, I think you probably agree with me that it's so critical for we as clinicians to remember to ask our patients about their medications, especially that we're all using electronic medical records, and sometimes we don't review with the patients at every visit what they're taking and make sure they haven't started anything new on label or non-traditional. And so it's a good reminder to all of us the importance of doing that. In addition to comorbidities and polypharmacy, we have an aging population in the United States, and a lot of our patients are older and frail. So even if they're not technically older, they could have comorbidities that cause them to be frail. So how do you assess for this, and how do you adjust starting doses or the way you monitor a patient? How do you fit that into your practice?
Depending on if I know this patient right or not. If you know the patient already, you kind of already have an idea of the performance status. And then the frailty, I usually like to ask a lot of questions just in terms of what are you doing in a day? I want to know what their activities are. And I know a lot of times they look at me a little funny, but I'm like, what did you do yesterday? What did you do the day before? Like, I really want to know like exactly what you're doing, just to know, to see how you're feeling and how you are. If we've treated the patient before, so we already know if they are more susceptible to side effects with medications. So if we've seen like they had a good amount of neutropenia before, or they had some GI upset, then maybe we don't want to start them at that highest dose of a CDK4/6 inhibitor. Sometimes our patients are nervous about starting a treatment and starting at that highest dose. And sometimes we will start at that first dose reduction just to see how they are. And if they can tolerate it, then, we can go back up to the appropriate dose. That's usually how I check for frailty and performance status in patients.
I love your idea of asking patients what they did the last few days. It's such a non-threatening way, non-judgmental, just sort of hearing about their life. And I think you can glean a lot of information, not just about their performance status, but who are they with? Who's around them? How did they get to the restaurant they went to? Are they doing gardening? Are they staying at home all day and not leaving? And you can ask questions like, are they, independently walking? Are they using a walker at home? So I really love that. And I think I'll incorporate that more into my own question asking. I love that I'm learning so much today already. But I think it is key for us to assess. There are some people who would, chronologically be considered quite elderly, but be really, really functional, super fit. And then there are younger people who may not be, who may really technically be frail. The more we assess frailty rather than a numerical age, the better off we'll be in terms of predicting toxicity. Let's review real briefly the CDK4/6 inhibitors and other therapies that we have to treat our patients. It's becoming an increasingly complicated time right now in terms of the treatment. So I want to kind of hone in on this just for a few minutes. In patients who have newly diagnosed hormone receptor positive, HER2 negative metastatic breast cancer, we now have the availability of not only 3 CDK4/6 inhibitors, ribociclib, abemaciclib, and palbociclib with endocrine therapy, but in those patients whose disease recurred while on or within 12 months of adjuvant endocrine therapy, we can test them for a PIK3CA tumor mutation, and if present, can offer them inavolisib-based therapy with fulvestrant and palbociclib. And then after disease progression has occurred, we have PI3 kinase pathway inhibitors, including alpelisib, capivasertib, and everolimus. We also have a novel oral SERD available, elacestrant. And so it's just becoming so complicated to discuss all of these therapies with patients and keep track of their toxicities and their indications. Which ones do we need to test for a particular mutation in the tumor for a patient to be eligible for them? So lots of questions come up, and it's so important for us to keep up with the pace of knowledge. So, La-Urshalar, I would love to hear how you choose among the 3 CDK4/6 inhibitors when you have a patient who is sitting before you and is eligible for all 3. What sorts of things do you take into consideration, and are there considerations relating to comorbidities that weigh into your selection?
What we know that we should be starting with at this point is ribociclib, but we do know that that can cause some QTc prolongation. So if there is someone that may have some cardiac issues, they've had some prior arrhythmias, or they're just concerned about having some type of the QTc, they're just worried about their heart, then sometimes we may not start with ribociclib. You do want to get those EKGs up front for the baseline, and then we're still doing 2 weeks and then day 1 of cycle 2. But if for some reason, let's say that their QTc is over that number that we're looking for, then we could turn to looking at palbociclib or abemaciclib. If we have an older patient or we have a young patient and they're working, then we got to worry about the diarrhea with abemaciclib. So a lot of factors play into that role. You want someone who is young to be able to go to work and not have to worry about running to the bathroom with diarrhea. So that is a big issue that we do try to address. All of them cause a little bit of fatigue, so that doesn't really help. I will say that if someone can't do ribociclib, then a lot of times we'll turn to palbociclib as our next course of or thought of treatment, just because you're not really going to have the diarrhea and the symptoms should be able to be well controlled. What do you do in your practice in terms of choosing?
I completely agree with you. Given that there's overall survival benefit with ribociclib and all the studies done in the first line and second line setting, that's our go-to choice. And I agree with abemaciclib. There's great efficacy, but the diarrhea and the tummy just not feeling great. Even when they're not having active diarrhea, they're aware of their rumbly stomach and an unpredictable intermittent diarrhea that can really get in the way of work, as you mentioned. So that would be a secondary. I think that palbociclib is probably the best tolerated. I'm just a little discouraged by the lack of survival benefit, but in a frail patient where I'm worried about QTc prolongation or diarrhea, I might start with that. Jordan, how involved are you in the selection of the 3 CDK4/6 inhibitors outside of insurance coverage? Do your clinicians work with you considering comorbidities and concomitant medications?
Like you mentioned, the frailty is a big consideration. I practice in West Virginia. I have a very elderly population, and so that's a very important consideration for a lot of our patients. But more specifically, looking at the concomitant medications, that tends to be more where I feel like I'm involved in helping select, because we, of course, do have a lot of patients on medications that can really interfere with some of these CDK4/6 inhibitors. And so with our premenopausal patients, we struggle with tamoxifen because of the contraindication with QT prolongation and ribociclib, but then also it's like a 3-fold increase in VTE with abemaciclib. So that can be tricky if we have a patient who really needs tamoxifen for some, reason as far as like a reason to not be able to use an aromatase inhibitor. That can complicate how many options they have. And then other like antidepressants obviously can interact with ribociclib and can be problematic. And so if we can adjust things a little bit to make it to where we feel that it is safe to use ribociclib, we do, as you mentioned, we really appreciate that survival advantage. So if we can get them to where we feel like it's safe, we will use it and monitor them closely. We have even done weekly checks instead of a day 15 check on a person that we felt like we should use it in, but we just wanted to monitor closer. So we can do things like that as well. And then kind of when we get to some of the other medications with hyperglycemia, there's of course a lot of not just comorbid conditions, but also a lot of drug interaction issues with the PIK3 inhibitor pathway medications as well.
Absolutely. And we haven't really even touched on the PI3 kinase pathway inhibitors, capivasertib, alpelisib, volasib, and everolimus, which have unique side effects and, in my opinion, are a little harder than the CDK4/6 inhibitors clinically. Without getting too detailed, maybe just in a minute, La-Urshalar, maybe you could take us through sort of if a patient has a PI3 kinase pathway mutation and is eligible to receive capi or alpelisib or everolimus, like how are you selecting among those three agents?
So I would say that alpelisib works well. However, it does cause some side effects that are hard to tolerate. It definitely can put someone in hyperglycemia where they're now having to take diabetic medications like metformin. So we do have to watch that. And then we also have to worry about these medications if someone's already a diabetic. Are they controlled if that's the case? Because then we are going to be, worried if they're not controlled, because alpelisib, as well as the capivasertib, can cause elevated glucose levels. And they're all causing GI side effects as well. So if we are looking and monitoring for those mutations and we see that PIK mutation, then a lot of times we actually are leaning towards capivasertib at this point. We will place alpelisib there as another choice.
These are complicated drugs. And as you mentioned, like the side effects really need to be disclosed to patients and discussed. And we have to assess their ability to keep up with communication with us. And I wanted to know, Jordan, if you're in your practice, you have any key insights in how you follow patients once they've started a medication? Are you relying on your nursing staff, APPs, or are the clinical pharmacists involved in calling patients and checking in on them?
It's really important to have kind of a multidisciplinary approach. It really takes the whole team to manage patients with the medications that can cause a lot of side effects, but I do tend to try to utilize our electronic medical record to set patient reminders at varying frequencies based off of when they start the medication so that I can call and not just assess for toxicities, but also for some of these medications with the hyperglycemia where they need the glucose checks. They don't always have the ability to come to our center for just that. It's quite a bit of travel for just that. So a lot of times that is requiring a phone call to follow up on some of those lab results and making sure they're being done and they're at an appropriate level to continue. So kind of evaluating both the laboratory monitoring follow-up as well as the tolerability of the agents in between visits with our providers. We work closely with our nurses as well, like you mentioned, to tag team on some of those things to make sure that adequate follow-up is occurring and patients are getting the monitoring that they need for these agents.
I guess one other question I have before we sort of hone in a little bit on the multidisciplinary team is real-world studies. And why is real-world evidence important? La-Urshalar, maybe you can speak to this a little bit. Our clinical trials are so heavily controlled in terms of eligibility criteria for patients to get on that they end up not really representing the span and scope of the population who will ultimately receive these drugs in our practices. So how do you feel about real-world evidence when you see posters come up looking at evidence regarding safety and effectiveness of new therapies for patients?
I love seeing the real-world data. When medications come out and we are able to actually dig deep and see exactly what the side effects are. I think the real-world data tells us a lot more because our patients are usually not super healthy when our patients are going on these treatments. And in the studies, they normally are. We do have good idea. We have the studies that basically tell us what we should be looking for in terms of possible side effects. And then we really have to look at that patient individually and see what already are they experiencing with their metastatic breast cancer. What kind of side effects are they already experiencing? And then how can we hopefully minimize any additional side effects with the treatments that we're giving them? Again, a lot of times these patients also, their ECOG is 0, so they're totally fine, right? And so we just have to take into account that everybody comes with a lot of different possible medications that they're already on, as well as comorbidities. That's basically what we were talking about previously. We just have to look at each one individual and then try to help them as best we can manage those symptoms.
Absolutely. I think we all have to rely on one another, right? It takes a village in the clinic to take care of our patients, especially with medications that have side effects that span other subspecialties. And that gets us to our considerations of the multidisciplinary team. Sometimes we're needing to reach out, as you mentioned, La-Urshalar, to our endocrinology colleagues due to the hyperglycemia associated with this, our pulmonology colleagues for patients with ILD or suspicion for pneumonitis, gastroenterology for the GI side effects, and ophthalmology for newer drugs that are having ocular toxicity as well. Are there any clues? How are you doing this in your own practice? Is the engagement with the multidisciplinary team something that's relatively seamless? Are there subspecialties that are harder for patients to access? And how do you contend with that, Ursula?
If someone is starting on one of these medications where we're worried about glucose levels, we do try to be in contact with their PCPs, and I'll tell them up front, I want you to go ahead and instant message or on your MyChart, your doctor, and let them know that this is what we're starting, that your glucose levels could go up, that things may need to be managed so that they already know up front when we're contacting them that we really need them to jump in and help assist us. I think the hardest thing sometimes is ophthalmology in terms of getting patients in, but we're working on that and working on getting a better way in terms of being able to get feedback from them in appropriate time. Everybody plays a huge part in helping that patient feel the best that they can on the medication. We use nutrition quite a bit in terms of helping them be able to get the nutrition that they need. But we also use them in terms of trying to talk about the supplements that they bring in. So our pharmacist is very hands-on. We have that person in clinic. She's great. And she usually gets all the list. Our patients are pretty good. Before they start something, they usually bring us a list of things that they're on or that they're considering taking. So our pharmacist will go through them and decide, what things they think are safe and what things are not safe. And then we also give them a reason as well so that they can understand why we're saying this is probably not the best supplement or herb that you should take.
That's great. It just speaks to the fact that, we have overlapping roles in many places and can help one another as we help the patient. And I love what you were sort of touching on, which is quality of life, which in many cases, we're wanting to balance quality of life with disease control. And it's so important for us to be focusing on that as we are treating our patients and trying to control their disease and make them feel better. So this has been a terrific conversation. I've learned so much, and I just hoping as we close the conversation that each of you could give me a key take-home message that you think our audience would benefit from. My key take-home is this is an incredibly and increasingly complicated time right now in terms of the treatments available to patients. It seems that there is an FDA approval at least once a year now of new agents. So it's really important for us to be tapping into activities like this to stay on top of it. Jordan, do you have a key takeaway from this that you'd like to share?
Metastatic breast cancer patients often have multiple comorbidities that require several different medications outside of their cancer therapies. And so because of that, multidisciplinary approaches are really essential to ensuring the appropriate selection of drug, appropriate monitoring, and then management of any potential side effects, because it is getting very complex and very complicated. So the more of us that are there to help take care of the patient as a whole, the better outcomes they have.
Well said. La-Urshalar, you get the final say here.
I would just say that it really takes the whole team. It really takes the whole team to be able to treat each individual patient, and that we just need to remember to talk to them and see what their goals are, because it is their quality of life that we want them to have, but we also want to treat them as well. So if we just think about them and work as a team to do the best that we can in caring for them.
Wonderfully stated. It's been an absolute pleasure to speak with you both today. Thank you so much for your time. And to our audience, thank you for your attention. Best wishes.
Thank you very much, Dr. Sara Hurvitz, Miss La-Urshalar B, and Dr. Jordan Hill. And thanks to you, the listeners, for joining us. As a reminder, to view the full program on comprehensive patient-centric care, in hormone receptor positive, HER2 negative metastatic breast cancer, meeting the full spectrum of patients' needs with comorbidities and related factors on the Clinical Care Options website. Please click on the link in the show notes. As always, thank you for listening.